have prepared. But before this, and even though it's lunchtime, you come from working, I try to put myself in your shoes and think about, how to give you value. I'm aware that new material, complex material is challenging, and the goal is by no means to achieve mastery of neurophysiology, of electroacupuncture in few sessions. It's just to lay the foundation to change the working methodology into one that will reliably and predictably produce superior results. I like to start with this because taking many training programs online, digital marketing, and so on and so forth. And I found this, one speaker that proposed that the product should deliver transformation, which is always my goal, that we agree. But then from there down, I'm not in agreement with any. Because it says you have to give results without overwhelming your customers. I'm sorry to burst bubbles, but you should feel overwhelmed. When you're faced with complexity, when you're faced with precision, with high-level engineering, you should feel overwhelmed. Otherwise, you wouldn't be here because you already would have arrived. So that's okay. And I say that's okay. I feel overwhelmed myself often through the many learning processes I put myself through, languages, driving machines, playing sports, etc. So no worries. If you feel overwhelmed, you're in good company. Then it says meet your clients where they are at and use the language they use. I'm very sorry, but I have no clue where you are at, nor do I have the time to figure out or find out where you are. So I would simply wait for you here and show you the path to get here if you wish to do so. And use the language they use. Well, part of my undertaking here is to give you new language so you can handle the new nuances and the new eyes to look at the familiar landscapes of pain with movement. And I think that's part of any learning process is language. Language is obviously symbolic, and every symbol means something. And through that acquisition of symbols, simultaneously we're acquiring knowledge. So I think this, pretty much the proposal here is to dumb things down. I don't think it's conducive to truly walk the path of excellence. And then answer the questions sometimes before they even know they have the question. Again, I'm very sorry, I'm not here to answer any question. I'm here to ask new and better questions and to propose you a methodology to ask better clinical questions so you can arrive at better answers. So I candidly disclose my approach and philosophy, which apparently collides with the party line of this world of dummies, frankly, in which people have aversion to complexity, while in actuality the universe is complex, life is complex, biological systems are the most complex things in the universe. Our job is complex, and we should embrace complexity. So, in a quick summary, the key points we review on part 2 of the presentation precisely included the knowledge that treatment approaches that are formulaic are characteristically inferior to mechanism-based approaches. Everybody wants cookie-cutter protocols, again, because people want the illusion of simplicity, even when dealing with the realities of complexity. But that is not the best approach. The best use of our tool that we can call a neuroreflex stimulation with acupuncture needles and electricity is to be crystal clear about the physiological goals of the intervention to begin with. And we emphasized in the presentation last time that the most salient neuroreflexes that acupuncture triggers included the improvement of vasomotor control, which results in improvement of perfusion, the most desirable physiological function, because perfusion brings oxygen, nutrients, and allows life. Then there is one that we will talk in the future a lot more in depth, which is the removal of neuromotor inhibitions. The neuromotor system is foundational to movement and therefore is involved in any dysfunction of the locomotor musculoskeletal system. Improvement in strength is characteristic after acupuncture treatments due to the removal of neuromotor inhibitions. Then there was a generic but very powerful and useful modulatory response at segmental level that involve every type of innervation that converges in the spinal cord, sensory, motor, sympathetic vascular, sympathetic visceral. And that results in some sort of improvement on all of the tissues supplied by these levels of innervation, so articular, muscular, vascular, visceral. Also, acupuncture by mechanisms that are mostly local through cytokines and other substances that act mostly at the local level improves the metabolism, the trophism of the tissue, and therefore improves tissue healing, improves metabolic cellular metabolism, improves tissue remodeling, even bone tissue. I know a couple of studies, PhD thesis actually on rabbits and dogs, showing in fracture model how repeated acupuncture accelerated healing, but not only accelerated, but normalized the organization of the trabecles, and that was accompanied by better levels of the enzymes that reflected bone anabolism and in comparison to the control groups. So this is phenomenal. These are some of the effects that we are still not fully using in clinical practice, but that they have research support to be introduced. And it's one of my favorites to use for sports injuries, to help healing. Then finally, at the bottom of the physiological effects, we had the neuromodulation of nociception, which obviously is a peripheral and a spinal phenomenon. We know nociceptive fibers not necessarily are going to trigger a neuromatrix response, a brain response. That will depend on the filtering of these signals by the different levels after the signals enter the spinal cord. And the result of it obviously is a decreased pain perception. Could be pain intensity, could be the quality. And then the final physiological mechanism that is engaged by the needles, the response of the nervous system to the needles, is the neuromodulation of the neuromatrix. Now is a complex central modulation involved in many levels, and that results as well in improved or decreased pain perception. We spoke about how knowledge of the peripheral nervous system, anatomy and microanatomy is mandatory to better understand nuances on the clinical presentations, and we will see that in the cases in the future, and as well as refine our strategies for treatment. And as part of these relevant topics, I like to simply highlight them, included the concept of segmental anatomy, the knowledge of plexular anatomy, the knowledge of fascicular anatomy, the knowledge of the nervi nervorum, the vasa nervorum, the structure, the microstructure of the nerve, the concepts of axonal edema, fascicular edema, perineurial edema. I didn't talk a lot about it, but the nerve can suffer a distortion of depolarization due to the presence of edema at different levels, which will stem from different reasons and will need perhaps different approaches to be solved. Also, we talk about the need to know the variety of sensory fibers, and we talk about the briefly classification, type 1, type 4, or the ABC with the subtypes alpha, beta, gamma, delta. And finally, the motor nerve classification, mostly alpha and gamma. Then also we talk about the need to understand the neurophysiology of the peripheral nervous system in terms of movement and motor function, because this is the number one purpose of the peripheral nervous system, to produce and control movement. And therefore, when we treat pain, we should put that second to the restoration of proper neuromotor function, because that is the number one purpose of the whole system. And oftentimes when you correct that, pain goes away because of the existing modulatory mechanisms between somatic motor fibers and somatic sensory fibers. We talk about the need to know segmental anatomy, because that way you can improve your ability to send signals to the same segment via different divisions. I gave the example of the femoral and obturator nerve, which are both from the same segments, but femoral nerve, posterior division of anterior rami, L2, L4, obturator nerve, anterior division, anterior rami, L2, L4. I introduced the concept of neuromapping of pain with movement disorders, which is a very broad topic, and which involve simply analyzing symptoms and signs from the standpoint of all the subdivisions of the nervous system, starting with the segmental ones: dermatome, myotome, sclerotome. That's the first neuromapping that everybody should be able to do quickly. So you point to an area of the body. I think I gave the shoulder example, and quickly you say, oh, this is a C4 dermatome, C5 myotome, C6 predominant sclerotome. And then if I say, oh, and how about peripheral nerve? Well, this is a cutaneous innervation, supraclavicular nerves, motor innervation to the deltoid axillary nerve, and branches from axillary and other nerves for the deep tissues, capsule, ligaments, etc. So this double mapping, segmental and peripheral nerves, is the first and basic methodology of neuromapping that I will show you how can be combined with neurofunctional analysis and then result in strategies to go from targets to inputs. So we are in the quest of trying to select the best available neuroreactive sites for our needles. And this is akin to chess. You can move one piece, that's it, to one square. Therefore, you have to be extremely careful in what you do. I've been doing this personal quest, which I'm almost there, doing puzzles in chess.com. I'm in the 99.8 percentile in the world. About 54,000, so only 54,000 people in the world are better than me doing that, but I plan to reach the 99.9 percentile, which I'm not sure I should be very soon, because I've been at 99.8 forever. But the point I want to make is a very good training. For instance, when you get a movement wrong, they take away 15 to 20 points, that then it takes you 4 correct answers to recover. And I like those challenges, and as painful as it is, it teaches me focus, it teaches me analytical skills that then I can apply to everything. I advise you, if you don't play chess, do yourself a favor, open an account, chess.com, and start later today. It's a fantastic gymnastics for the brain, but also it has many commonalities to what we do. For instance, the difference between strategy and tactics. Tactics is the specific movements. Strategy is the understanding of the global nuances of the position, the same as a clinical case. Indeed, I got many of my good ideas from chess, just sharing with you my enthusiasm for the game and advising you to use it for your own mental gymnastics. So I think I cover everything, and then I like to jump into what is going to be now the more technical. Now we're going to get technical, and you're going to see how many of these parts of the conversation are going to converge. A goal is not the same as a target, and obviously it's not the same as an input, but they are all interrelated. Goals, I will only remind you about this categorization and this clarity that this hierarchy I have found to be the most useful. So if you think that an area may not be getting appropriate perfusion, put your effort first and foremost in restoring perfusion. If you think that a joint or a set of joints, a kinetic chain, is not acting in a full neuromotor engagement, then restore that, and you'll restore it by stimulating the involved muscles. If you're not sure what's going on, by all means, and as part of all treatments, target the segment. And a lot of improvement will ensue just from that strategy. Okay. I spent time the other day here, but I wanted to take it a little bit behind from where we finished, because I understand this is the most difficult part that we are starting to navigate. So, goals. And also, a disclaimer, I don't think like this. I've already integrated all of this, and I think very differently, like the big players, the super grandmasters in the world. When they explain how they operate, it is very funny, because they all say that they calculate very little. And what they mean is not that they calculate very little. What they mean is that they calculate subconsciously. The same way I process clinical information, and any practitioner with a lot of experience will do. It's like when you're talking, you don't think about the words specifically. The words come to you. You want to say something, and when you have enough practice and enough database, they come to you. So let's make no mistake. At the beginning, the process is like speaking a new language. It's painful. It's a little robotic. It's choppy, and little by little it acquires fluency. So that's part of any learning process. Don't try to get it perfect. Try to understand enough about the problem that your input has a higher level of intentionality, that's mechanism-based, science-based, and not paradigmatic, regardless of the paradigm that you may be using. Because a paradigm is accepting that you're acting with a blindfold, while the freedom and the empowerment of using a mechanism based is phenomenal. And also it allows you better feedback and better assessment of the effects of your own interventions. Well, if you use non-paradigmatic models, you don't know. You don't know what you hit that helped, or you don't know what you didn't hit that didn't help. That's why this is superior. Like analyzing a chess position is superior to just moving the first piece that crosses your mind. So remember the segmental neuromodulatory mechanisms, very important. Remember the local ones and the supraspinal ones. So now what I'm going to do is, this part we talk is to get to how I arrived at the standardized methodology that you can call contemporary medical acupuncture or neurofunctional electroacupuncture, which is a product simply of repeated analysis and organization of the information into a not paradigm, but a system that's anatomy and physiology based. So at one point, I studied every method of acupuncture, TCM, 5 elements, some Japanese, some Korean, some etc., some French meridian, so on and so forth. And then trying to achieve that minimalism, that understanding, one day I realized, okay, if we have a problem, if we put a needle, that needle either is neurologically connected to the problem or is not. And that was my aha moment. That was my Archimedes eureka moment, because that in one stroke organized for me forever and ever all the inputs. Once I define the dysfunction, now I can choose to put needles in the neurologically relevant territory, and you can define that peripherally or segmentally, or I put the needles elsewhere, extra segmental inputs. And then quickly, the segmental inputs, you can either put the needles along the trajectory or receptor sites of the peripheral nerves, the plexus and the peripheral nerves, and I call that, for language easiness, local inputs, because obviously most of those needles are close to the area at fault, not necessarily right there, and I'll explain that. Neurological locality. For instance, very quickly, if I have an acromioclavicular joint problem that and I want to put a local input, doesn't mean I need to put a needle there on the joint, although I can do it, but I can put a needle on the neck, posterior to the sternocleidomastoid, on the so-called Erb's point, which coincide with the description of LI18. Anyway, is the trunk of the supraclavicular nerves. That's what it is. So that needle, by virtue of the neurological connection with the area that the brain is perceiving as having the problem, is a local input. So that's what neurological locality means. Not physical, anatomical, necessarily, although oftentimes coincides, but neurologically. So anything you put on the trunk of the supraclavicular nerve, obviously is going to have an effect on the whole area supplied by the supraclavicular nerves, including skin, acromioclavicular joint, acromioclavicular ligaments. Then the second dimension of a segmental input refers to the shorter branches that come from every segment and that supply the vertebral, the paravertebral muscles and the intervertebral joints, which are the posterior primary rami. And the posterior primary rami have names that coincide with the vertebral level where they stem from, and we have C2, C3, etc., posterior primary rami. So those for language easiness, I call axial inputs because they are located along the spine. And for those of you studying classical acupuncture, will coincide with governor vessel points, with bladder points, except that this concept of neuroreflex, neuroreactive sites is broader and gives you freedom. It's a freestyle. And it gives you a better ability to generate inputs, as we'll see as we go along. There is a little subdivision here that you can see in the diagram. It says anterior rami T1L2. The anterior primary rami mix and mingle into plexuses. We have cervical plexus, brachial plexus, lumbar plexus, sacral plexus, coccygeal plexus. But in between T1L2, we don't have plexuses. We have just the intercostal nerves that go around the ribs, and those just for completion, anterior trunk inputs. But you could ignore them and just, when you need to put needles there, you put needles there. It's another type of local input. So now we have segmental acupuncture is as easy and as simple as I just said. Either you put needles along peripheral nerves that have names and come from specific plexuses, or you put needles on posterior primary rami territories that come from segments that are relevant to the problem, whether the relevance is dermatomal, myotomal, sclerotomal, or the reflex vascular sympathetic level. So with only two categories, I already cover most of the inputs that I use, that you use in clinical practice. But then there's another subset and another complementary and even sometimes possible single approach by itself, which is to put needles in miscellaneous location with the intention of triggering central effects. So I call that systemic regulatory inputs. That include auricular, obviously, and include the typical classical distal insertion sites that, by the way, are the ones the most used in the history of the therapy to this day. When I started studying acupuncture, obviously I read all the studies that I could put my hands on, and I asked one question, which is always the critical one. I said, I don't care what people say they do or why. I want to know what they do for real. And when someone, such as myself, asked that question and in a group of practitioners, well, they found out that the majority of people were doing exactly the same. They were doing Li4, liver 3, spleen 6, kidney 3, gallbladder 34, stomach 36, little more. Now, I reversed the question. I said, what would happen if I were not to use those neuroreactive sites? And as I play with many different inputs, in my own non-control research, but research nonetheless, I can tell you for a fact, and you probably will say I'm right even without trying, that if you don't use those points, your results are going to be dismal. And you'll be totally right, because those are the most powerful neuroreactive sites centrally. So the distal arteriolar networks, for instance, the radial artery here on the first interosseous dorsalis, so it doesn't matter where you put the needle, if it's an Li4 by the book of the Yellow Emperor, or an Li4 by the book of someone else in a different course. It doesn't matter. You put a needle in this region and you are right on a very rich area of small arterioles which have numerous sympathetic receptors and therefore is very reflexogenic. Also, all of you are familiar with the reflexogenic power of pericardium 6, or master of the heart 6, depending on the countries and the language, is a neurostimulation site right over the median nerve. And that results, among other things, in sympathetic changes at the heart, slow lowering of the heart rate, but also control of the nausea and vomiting in pregnancy. That is not magic. That is not something that nature put a button there. No, that's simply a neuroreflex that involves sympathetic fibers that are part of the median nerve, the median nerve being the most sympathetic or reflex nerve on the upper extremity. The same way in the lower extremity, this category is going to belong to the sciatic nerve higher up, which really is two nerves, not one, tibial nerve plus fibular nerve, or on the fibular nerve. That's why gallbladder 34, the universal point to modulate activity in the muscles, tendons, sinews. Again, it's not magic, and again, it's not a specific. It's a simple, good place for sympathetic modulation. In my career, I play with all these, and I've sometimes done things in a fastidious manner just to prove people my point. I can make a shoulder move if I put a needle on the TCM joint. I can do the same, putting the needle in 20 different places. One of the myths of acupuncture classical acupuncture is specificity. The majority of responses, except for the local responses, are segmental and suprasegmental, and therefore there is no specificity. And the fact that you use certain approach and you get results doesn't mean that you were right about your explanation. What it means is that you touch relevant mechanisms. So the power, to me, of understanding neurofunctional acupuncture is that liberates yourself from any beliefs and also gives you tremendous freedom and tremendous precision. There is no other system of acupuncture that's more precise, and I'll show you why and how. So let's go to all the categories. Once I understood this, then I categorize. I say, okay, let me see, where can I put needles locally at the peripheral segmental level? And I went and researched all the categories of sensory receptors, but also all the preferred access to the neuromotor system that gave me the ability to send an input, a powerful input, particularly an input that produced muscle contraction. And also, almost in a hierarchic level, here is the result of my empirical research and 30 years of practicing the method. The number one, if you tell me, okay, you can only treat your athletes doing one thing, it'll be very easy choice. I would say I don't need LI4, I don't need liver 3, I don't need gallbladder 34. I need motor points. Why? Because if I do a motor point by definition is the area where the motor nerve penetrates the fascia and gets into the muscle fibers. Because it does that, it generates an area of lesser electrical resistance where less electrical stimulation triggers a depolarization, therefore a muscle contraction. And the motor points are very well known for many, many years. So, and you can do motor points by itself without electricity. That's dry needling, which is a little bit barbaric, painful, and unnecessary when we have beautiful electrical stimulators, and you can do the whole thing painlessly and elegantly. But there's a whole system dry needling, very popular in the world, particularly among physiotherapists due to historical reasons that I will not get into. But again, our method is superior, stimulation with electricity. So motor points typically are consistent anatomically in every muscle. Some muscles have one motor point, some muscles have two or more, depending on the size of the muscle. Muscles that are round, the motor point is in the middle. If they're a little longer, typically then is in the junction of the 1/3 with the 2/3. There are many anatomical studies in the last 50 years that have researched the presence of motor points. I have many of those and I use them. At the end of the day, finding motor points is a combination of knowing anatomically where they should be and then palpating and feeling the typical difference in tissue pliability that happens because of the presence of that nerve fiber. And typically, because the nerve fiber there, the peripheral nerve is thick, it is very easy to feel after a while, after a period of just tentatively. But even if you just know where it is or should be and just go there, and when you feel something different, put the needle, little by little you will find more consistently the motor points, particularly the big ones. Because there are other smaller motor points that you can describe as simply secondary motor points, or one category that's in discussion. Some people argue they don't exist, which is the trigger point. The trigger point, there's a whole series of books, two very thick books by Janet Travell and David Simon, and those have been popularized as well among the physiotherapy profession mostly, but among all health professionals. In recent years, it's been argued that they have no anatomical existence, which I don't disagree, but definitely they are functional trigger points, meaning areas of hypersensitivity that when stimulated trigger sympathetic activity as well as refer pain, meaning pain in an unrelated area. For instance, and the book, I studied Travell's book from cover to cover, and I used it extensensively, and I actually developed some techniques inspired by the injection techniques proposed by Travell. And when people used to ask me in the old days, they asked me, okay, can you recommend an acupuncture book? My answer was always, well, I can recommend you a book that's not per se an acupuncture book, but I think it's going to be the most useful of all the books you can read, and is the Myofascial Pain and Dysfunction, the Trigger Point Manual, volumes 1 and 2. And you should read every day, one muscle, two muscles, and little by little you will have a map of what it tells you. Obviously, not everything the book says is like religiously truth, but it gives you a very good foundation to understand the possible involvement of proximal structures into symptoms that are perceived distally. For instance, very common, the lateral epicondylar pain, pain felt around the lateral epicondyl of the elbow. Travell tells you that there's a trigger point on the supraspinatus muscle that mimics and triggers that. Because I've done a lot of palpation, I can tell you for a fact that there are myriad of patterns of referred pain. Now, one problem we have in medicine, in science, is that we quickly like to categorize things into close absolute categories because that is intellectually soothing. Well, in actuality, even anatomy is generic. There are many anatomical variations in everything, even the structure of the muscle, the microstructure, even the macrostructure. Some muscles have an extra belly. Sometimes in the shoulder girdle particularly, there are extra muscles or missing muscles. And we're talking about the macroanatomy. The neural anatomy is even more. There are more variations, and you know that even internal organs, there are people with one kidney, there are people with weird things. The more people born, the more anatomical variations. So let's not do that. Let's accept that we have to operate in an open architecture system where things are not written in stone. And trust me on this. If you find something in a patient, that is true. That is true. Even if it's the only person in the world that you press here and has pain on the baby toe, on the contralateral foot. And let's not try to explain things 100% all the time, because it's not necessary. I mean, you know very well that, for instance, a person under stress will quickly manifest a myriad of somatic symptoms, pain, sharp pains here, shortness of breath, this, that. So autonomic dysregulation by itself is a generator of symptoms. So in this case, my summarizing on this arm, by the way, I like very much, because I think I was able to represent here something that I always wanted to do, which is all these categories. But at the same time, you notice that I took the artistic liberty of making a microscopic structure such as the muscle spindle into a macroscopic one, which obviously is inaccurate, but is visually powerful to remind us that, needle in the belly of the muscle is already a technique. And indeed, anybody who puts needles in the muscle, even if they put them randomly, they're going to have some sort of response, because they are going to engage some of these mechanoreceptors. Other areas that are highly reflexogenic and that deserve attention in clinical practice include the muscle tendon junction that has here represented a Golgi tendon organ, as well as near that area there are other mechanoreceptors such as Pacinian corpuscles, and also there are receptors on the attachment, on the tenoperiosteal attachment. So these are preferred areas to engage your needles with the muscles, and not with the muscles per se, but with the nerves that innervate these muscles, the sensory and the motor. So preferred areas are going to be tenoperiosteal attachment, muscle tendon junction, belly of the muscle, and then any tender spot on the muscle and the motor point, which typically is not tender. So these 1, 2, 3, 4, 5 are the summary of all the categories of neurological innervation, also all the categories of neuroreactive sites, and what are the most commonly associated nerve fibers, type of nerve fiber, type of receptor. With this, if you now polish your needling and start doing your local inputs more refined, you will see another level of response. I mentioned to you one study in rats where the muscle contraction was necessary for mean arterial pressure to lower, and so they found that even in anesthetized rats, muscle contraction was more powerful. Also, very simple idea here. when you do muscle contraction, simultaneously you are triggering a myriad of sensory inputs, because if the muscle contracts, there is activation of the sensory receptors of the muscle spindle. There is activation of all the mechanoreceptors, Pacinian, Ruffini, Golgi tendon organ. So when you contract a muscle, simultaneously you put in motion all the sensory dimension. That's why of all the inputs, if you ask me what is your preferred input, I would tell you in no uncertain terms is motor points, to make the muscle jump painlessly at a frequency of 10 hertz, because I use a pointer plus, which was not invented for this purpose, but that I recycle into a acupuncture needle stimulator, and all our graduates in every country, Canada, the United States particularly, and Spain, they've been using this technique and getting the pointer pluses into their treatment bag. And indeed, I always travel with two, like a good slinger. The military taught me that 2 is 1 and 1 is none, and I could not work without my pointer plus. So if you ask me, okay, if you only have one needle and one technique, what would you do? Most of the time, exceptions of course exist, I would focus my attention on a motor point and stimulate it electrically, and that would give me simultaneously neuromodulation of the segment, sensory and motor, would remove neuromotor inhibitions, would reach the brain and trigger miscellaneous central neurohumoral responses. It truly is the closest thing to a magic act that you can do with the needles, if you wish to do so. But it's also a game I play, and I ask my students to play, which is, if you only have one needle, where would you put it? Indeed, the first about 900 acupuncture treatments I perform, I already limited myself to 5 needles. And why? Because I said, okay, if you're going to continue doing this, is because you are going to understand it. And if you're going to understand it, you really have to be good at selecting. You cannot put 20 needles like people put, because I told myself, you need to understand and you need to predict better the results. So I was obsessed with that. I didn't allow myself to use electricity. 5 needles, 5 minutes, and that was it. And even with that, I already got significant results, and pushed me to the selection of the best targets and the refinement of the understanding. Then the next 900 treatments, another year, my second year, I still limited myself, but then I allowed myself to use electricity, and that's when I started creating the foundation of what's now the blueprints. And that's how I built my own system, by challenging things from day one and not postponing. Now that's my curiosity and my way of doing things. I'm more of a researcher that way in my brain, although I'm a very good practitioner. My hands are very good, but that's something I discover later on. So I invite you to play this game, do less, and try to find out what has the best effect. Now, other areas where we put needles that are very good targets involve any peripheral nerve, either together with a vessel, neurovascular bundle, or simply a sensory branch or a motor branch. The fascia also is a good target. The space between the muscles, the interfascial areas, are good as well. Healthy tissue surrounding damaged tissue, that's a very old approach surrounding the dragon, it just makes sense, because what you do is like a sort of PRP, if you wish. You just trigger positive local responses in an area that's very active because it's close to the damaged area. And then you can put needles, obviously, into connective tissue associated with the joint, ligaments, capsule. The final area in which you can put needles is the distal arteriolar networks, and that summarizes, this arm contains all the acupuncture atlas you ever need. So if you know anatomy, I've already taught you all the insertion sites. You don't need meridians, you don't need categories. You need peripheral nerves and their receptor sites. And I can prove to you, wherever you put a needle that has an effect is because there is relevant innervation. The end. That admits no discussion. It can be done easily, daily, and it's something that you truly need to embrace from today and start your transition to analyze things neurologically, and then insert the needles neurologically, because they'll have more effect than if you do it using any other system. Local inputs, real life example, and why it's important to embrace this model. For instance, I'll go here to this quadrant. This lady, which came to a championship, that was World Track and Field Indoor Championship in Birmingham, I believe in England, sometime in the late 90s, and that the year I don't remember. And this lady had qualified, but suffered what was labeled as a hamstring injury, and because it was on the few days before the trip, they said, well, anyway, go, and that way you get treated. And okay, so she came, and they asked me, can you take a look at her? She's not going to compete, but it would be great to start her rehab. So I examined her, and the first thing I conclude is that there's no hamstring injury. I'm very sorry. The people who diagnose this, they lack anatomy knowledge, and the muscle that is affected is the adductor magnus, the biggest deep muscle that we have in the body, adductor magnus. And also, I didn't appreciate that it was really torn. It was spastic. It was suffering a little strain, but nothing. It didn't feel like it was anything major. So I proceeded with this type of input, and these are 8 75 millimeter needles that are fully buried into her adductor magnus proximally. Now, if you look at the acupuncture atlases, there are no meridian points here. Also, if you practice very traditional acupuncture, you don't even have 75 millimeter needles. So I've been at the home of one of my friends in Belgium to teach a course, and I say, okay, give me 50, 75s. And he said, what do you mean? I only use 30s. I said, you're kidding me. So you've been doing acupuncture for 20 years and you only use 30s? And he said, yeah, I just do acupuncture energetics. I say, okay, I'm very sorry, but you know what? There is a superior, the same way that a gun is superior to a bow and a motorbike is superior to a bicycle, deep needling is superior to superficial needling, because they are deep muscles that if you don't reach them, you're not going to be able to modulate activity there. So this is a prime example of how having the right understanding and the right tool is so powerful, because I put those needles there. You can see that they are connected to a double circuit with an Ito at low frequency, 1 to 2 hertz. I do that 10-12 minutes. I think I added some distal points for sympathetic modulation, and probably I added some axial points. The fact is that after the first treatment, this is, oh my God, I feel like 80% better. This is ridiculous. Say, I love to go and do some training, still, because my event is far, it's next week. Like there were like 6 days we had. I said, by all means, go do it, come back, give me feedback. To make a long story short, this approach resulted in her being able to compete and win a silver medal. A person who was discarded with the wrong diagnosis, number one, which is very common in pain problems, not just sports injuries, and then the right tool at the right depth, all based on anatomy and neuroanatomy. So this is the power of the system that I'm proposing you embrace. This is another world-class sprinter during another event. And this is to highlight one strategy that's very ancient also, but is very useful. Locality, as I described before, means that is neurologically connected. And that includes the contralateral side, because when the signal arrives at the spinal cord, there is overlap between right and left. As you know, you can train one side, one leg, and the other leg will improve up to 15% in strength due to these cross innervation mechanisms. So it's totally legit and advisable to stimulate the same nerves on the contralateral side, on the good side. So this is a sprinter with a long head of the biceps there. You can see it clearly, where this is probably day 3 or so. At day 3 we already introduce electricity. Here's the Ito, low frequency, a proximal point along the sciatic nerve. You can say it's bladder 36. Who cares? I will not use that. I just tell you that many of the traditional points obviously overlap with peripheral nerves, but others don't, and they're valuable points, such as these ones on the Dr. Magnus, that are not to be found anywhere. So that's where you have to learn the anatomy, and the anatomy of the peripheral nervous system. So here we have the proximal, the distal, which is in the short head of the biceps, and these are just 4 needles surrounding the injury that now is healed enough to tolerate electricity. And on the contralateral side, I do here, that would be, again, bladder 40, the tibial nerve, and here the sciatic nerve. The tibial nerve is one of the 2 components of the sciatic nerve. So really, what we're trying to do is to send input along the same nerve, so the power of the segmental modulation is heightened. So these are some examples of how to profit from this knowledge. This also is a median nerves related issue. Well, here the needles clearly go to the pronator teres muscle, to the 2 bellies, and then to the proximal attachment here on the humerus, and then a couple of needles along the median nerve itself, low frequency. Inputs like this, all they require is the palpatory skills and the knowledge of what is there, and they're inputs that don't require a protocol, a book, or nothing. You can make it, it's a basic musical notes that you can play in your instrument once you know the notes. Here my friend Donovan Bailey, whom with I worked for many years until his retirement, and how he used to love these inputs. These are 75 needles all going into his gluteus maximus and medius, and he always had a left side overload and a tendency to cross the left shoulder and strain the parascapular, and he loved this kind of input. This was done at 15 hertz, not 2, making the muscles jump, and he would feel really activated after these inputs. And interestingly enough, years later and before the end of his career, he torn the left Achilles unexpectedly during a pickup basketball with some friends. And it's interesting because he always had issues, but never a day of complaint on his Achilles. and the first thing we knew is like gone. And then years later, after retirement, he continues to play basketball to this day. He torn the other Achilles, which indicates some sort of issue segmentally on the L5 S1, but also the fact that he's born Jamaican and lives in Canada where the sun doesn't shine a lot. So vitamin D deficit is a very common underlying cause for tendinopathies, tendon ruptures, that again I invite all of you to include that knowledge into your daily practice, how the metabolic dimension is so important. So just to wrap up today's, I know you have to go back to work, so I'm going to keep it a little shorter, this other one. We have the anterior inputs of the trunk. They're just done over on the intercostal spaces. Obviously the needles are not put like this in the illustration, not perpendicular. I use the threading technique, and the needle goes parallel to the wall. Actually, I have a video I'm willing to share with you, 58 minutes of discussion of techniques, needling techniques on the trunk, which I think would be very valuable for the profession, because it contemplates all the safety issues related to the pleura and related to the abdominal viscera. And so I will send that to Sulin, and she will create a link for you guys to access just this group. Here, the paravertebral musculature, where the two divisions of the posterior primary rami, medial division, lateral division, can be found, and the most reflexogenic area is the one closer to the midline. So if I've had to choose an area to put needles on the back, I go one thumb from the midline and I stay there. Nothing major to be added by going more lateral, and the more lateral you go, the riskier it is, because the narrower the wall, particularly in the thoracic spine, and the higher the risk of pneumothorax. When we reach the technical parts, I will talk about pneumothorax to you and how to avoid it, which is very, very simple. And it's an unfortunate adverse event that I think is almost 99% avoidable. Nothing is 100% avoidable, but 99%. So here, again, the mechanisms that you know, this is only a reiteration of the mechanisms, and this is the example of how technically the axial inputs go, and they always have two dimensions. I always put 8 needles per axial input, and 4 are going on the reflex sympathetic vascular level, in this case T10, L2, and then the other 2 go on the somatic relevant area. So if there is a hamstring injury, I could choose anywhere from L4, L5, S1, S2, and then T10, L2 to modulate activity on the vessels, and then the use of the contralateral. Here you can see the whole thing. And the combination of these axial inputs with the local inputs is the foundation of the method, and was given me tremendous success in the athletic community, the high performance. In this picture you're seeing, this was a silver medalist in Sydney. This was a world record holder of the 100 meters. Marla Ruyan. She was a legally blind athlete, the first one to compete against fully able athletes. She was legally blind, could see something but very little, and she was a tremendous competitor, and I had the privilege to work with her many years of her career. Okay, and I'm going to leave it here because the systemic regulation is another chapter, and we're getting there. And then after this, we're going to go, I will show you, we're going to go to the Neurofunctional Acupuncture Blueprints, which is the protocols based on the knowledge of articular innervation, area by area, and really how can you maximize this knowledge and how can you implement technically all what we've been talking, But I needed to spend the time laying the foundation because otherwise it's impossible. I would have to stop every 5 seconds and explain something. So I will stop sharing, go back to the main screen and take your questions if there are any.
Thank you, Dr. Elorriaga. It was nice to have at least a little mini case presentations about some of the examples to really kind of highlight how paying attention to some of the techniques you're talking about, how it can make such a difference in the treatment outcome.
We're getting there.
We're getting there. Okay. So we have a comment just about a notice many acupuncturists are doing superficial and sticking to tradition to limit the number of needles. Thanks for your teaching and the lecture.
You're welcome.
Does anyone have any questions for Dr. Elorriaga? I know that we're continuing. This is part 3. And again, anyone who's attending will receive the video that he had mentioned. I'll make sure to send that out for you. If not, I think we'll let you all go, and thank you very much. Sorry. People are now hopping in. Is it fair to say that your approach is more principally based versus a cookbook? For example, you treat 2 patients with similar pain differently?
Indeed, not only you treat similar presentations differently, you treat the same person differently every single time. One of my proposals is going to be that you revisit and sort of not re-diagnose, because you're not diagnosing, you are mapping. So every time you remap to know where you are. It's like you take a car and then you feel something. You tell the mechanic tweaks that, then you take the car out again and then you feel something else, and so on and so forth. So I'm proponent of an open system, free style, but the free is not free. It's physiology, anatomy, principle-based, and it has numerous rules that we're taking the time to review. So it's a challenge, and that's why I said before, I don't expect anybody to feel comfortable. I would not be doing my job if you feel comfortable. So by all means, enjoy your overwhelm.
And is your experience with providing, what's your experience with providing inputs for lumbar pain in pregnancy? So are there any trimester concerns?
Oh, that's an easy one. First of all, pregnancy is not a disease. That says it all. Pregnancy is a heightened physiological state where women are physiologically at their peak of adaptability, and therefore is the moment of least concern to me. Although culturally we've medicalized pregnancy and come up with absurd notions and ideas. A pregnant female mammal, human included, can proceed and live normally all throughout the pregnancy to the day of delivery. So please, don't be afraid. Studies have been done trying purposely to trigger abortions, and it didn't work. There's a percentage of spontaneous abortion on the first trimester, and that's what's going to happen whether the person receives or not acupuncture. And it's a myth that you can trigger even delivery. We've tried many times, and delivery comes when delivery wants to come. Trust me, we've done that, and our wives, the wives of friends, and we don't have that power, and we don't even yet understand the complex mechanisms under pregnancy and delivery.
Do you find any need for needles longer than 75 millimeter, than the 3-inch needle?
Yeah. When you deal with athletes, 10 centimeters may be needed, and even 12 for a technique that is not an acupuncture technique that I do, which is a lumbar plexus through the back. It's very safe, but not everyone will feel comfortable doing. That would be my longest needle, is a lumbar plexus stimulation below L2 on the right, L3. And between L3 L4, I use that needle, but I use 1 or 2 a year. The rest, 75, is my longest needle standard use.
And I know you were talking about your limiting yourself as a challenge to just 5 needles in a treatment. Was that more
First
to
year.
help you think outside?
Yeah, was to push me to truly understand the value of what I was doing. Basically, I was testing the reflexogenic power of the different sites based purely in empirical evidence. So people would tell me, oh, use this, use that. Okay, very nice. I will, but I will under my own testing. So I'm a little bit like St. Thomas, I need to see it, I need to touch it.
And your concept of goal, targets, and inputs, does this concept minimize the need for a specific diagnosis, or just means, or help with intervention once you have a diagnosis?
Well, the word diagnosis is quite misleading because in actuality, diagnosis needs a second word. You can have lab diagnosis, you can have imaging diagnosis, you can have functional diagnosis, you can have clinical diagnosis. What I'm proposing, instead of a closed system of categories that is not helpful in clinical practice, I'm proposing a mechanism-based that you apply to a neuromapping where it's descriptive of what's going on. Because nobody can claim that we really, really know. You start talk to a neurologist. Ask a neurologist what multiple sclerosis is due to. What at the end of the day, we know very little about truly what's going on in the human body. That's why for most problems involving pain, we know that motor system is involved. We know that some sort of segmental dysfunction is involved. So I'm a proponent of a system that touches as many relevant levels as possible. It's a sort of neurofunctional diagnosis. You can call it like that. And then medico-legally, I don't know, depending on your profession. That's why neuromapping, I think, is beautiful because it's non-denominational.
And would you suggest a spinal manipulation technique before or after needling, or does it not matter?
Very good question. I think the beauty of the needles and the neuromodulatory power and the restoration of perfusion is such that oftentimes the mobilization of the articular region happens spontaneously. Indeed, we have many chiropractors, graduates of my program at McMaster and all over the world, and they reduce their manipulation by 80 to 90%. And although I learned osteopathy and chiropractic manipulation myself, I rarely use it because what I do is after the needles, I then use my soft tissue technique and the mobilizations happen spontaneously. Safer.
And are you always doing bilateral body treatment? Is that important?
I would say most of the time, but my treatments are very long, so I have time to do both. But there's nothing wrong with one day in a sequence of treatments to focus only on one side. I think there's nothing wrong with that per se. But if you're going to treat long-lasting issues, you need to do segmentally, at least bilateral. So my segmental input would be bilateral 90% of the time. Then you can focus on one side only, one arm, one shoulder. But the segmental, bilateral, I find it's more useful.
So if you are doing the one side, would you want to do the other side in close?
I do it simultaneously, so I figure out a way. So even if I do it sideways, recumbent, you can put the needles bilaterally on the segmental. That's the beauty. For the lower, it's more comfortable to do it prone. I mean, we can talk technical things. But for the upper, you can do it perfectly on lateral recumbent position, no problem.